Great. My name is Wendy Stead, for those of you that I may never have met before. I'm one of the infectious disease faculty at Beth Israel. I've been doing this ID work for about 20 years or so now, and I'm interested in a lot of different areas, but actually started working more closely with Dr. Carroll and the Boston Lymphatic Center probably about 5 or 6 years ago. Really trying to help seeing and manage patients who are suffering from chronic infectious related complications of lymphedema. And so that's what I'm here to talk about today. I don't think I have to tell anybody in this group that it's a pretty common complication of lymphedema, and so one that I think it's worth knowing about. Let's see if I can advance my slides. There we go. Okay, so I wanted to start with a brain teaser. I'm sure you guys have seen stuff like this in magazines and online, these pictures about try to find as many of something in 20 seconds that you can. This one's cats. We're not going to spend time on that. But I wanted to use the same kind of brain teaser and apply it to legs. And I'm guessing that these pictures of legs, which I got online, are probably fairly familiar to everybody that's watching this webinar right now. In fact, you may have just walked out of your clinic and turned this on and just seen legs like this within the last few minutes. And so I just want you to look at these for the next 10 to 20 seconds or so, and think about how many risk factors you can see immediately as you look at these legs that put these patients at risk for skin and soft tissue infections. And I think it's pretty clear that there are there are a multitude of risk factors here that we're going to talk about. And so certainly, these are edematous legs, and they have lymphedema, and they probably have some venous insufficiency as well, as I'm sure you know those two things often kind of travel together and have a complicated interrelationship. You probably can't see it exactly, but you can bet that there's some tinea pedis on these feet. Those toes are pretty squished tightly together, and I'm sure that it's very moist in between those toes, and probably very likely that some fungal organisms have set up shop there. These legs are likely to have, particularly the ones on the right, stasis dermatitis from their chronic swelling. And so we see a lot of skin complications of chronic venous insufficiency, which travels with lymphedema. Ulcers as well can be a common complication. And then with more advanced forms of lymphedema and stages of lymphedema, you'll see other skin changes like hyperkeratosis, dryness, cracking. All of these things add up to enormous risk in these legs for skin and soft tissue infectious complications. So this is just a quick roadmap of the ground that I'm going to try to cover in the next 25 minutes. I tried to shoot for 25 minutes so we'd have time at the end for questions, but please feel free to ask questions in the chat along the way as well. I can certainly stop and answer things for pressing questions. So we're going to start with a very quick look at trying to understand the relationship between lymphedema and this increased skin and soft tissue infection risk. Then move into diagnosing and categorizing skin and soft tissue infections and how we do that, how we think about that in medicine. And then also, what are some cellulitis mimickers so that we don't get tricked along the way. You all know that every red leg is not necessarily an infected leg, and there can be some common infectious mimickers that we don't want to fall for because we don't want to treat unnecessarily with antibiotics. I'm going to review some basic high points of treatment for active skin and soft tissue infections. Quickly review some of the common chronic lower extremity ulcers that we see, not necessarily because lymphedema itself causes a lot of ulcers, but it travels with other comorbid problems that do. And that can affect infectious risk for sure. And then I think the most important part of this talk will be reviewing effective prevention strategies for recurrent skin and soft tissue infections. Every skin and soft tissue infection that these folks have probably increases their risk for more future infections by, again, damaging their local lymphatic system. And so I think it's really important that we know good ways to try to avoid these, and there are good ways to try to avoid recurrences. And then if we have time at the end, I'm going to give you a very brief word on filariasis, which, although it's not at all a common entity that we see here in the US, if you work in any clinics where you see large immigrant populations, is probably something that you want to know about because it is by far the #1 cause of chronic lymphedema globally, although not in the US. So why are lymphedema patients at such increased risk for skin and soft tissue infections? It's really a multi-hit phenomenon for them. We know that the lymphatic system is really the most important kind of infection fighting system in our bodies. And so decreased lymphatic drainage will alter the immune response in tissue just by its very nature. The fluid that's left behind is often very rich in proteins and makes an excellent medium for bacteria to grow and cause problems. The chronic edema and dermatologic changes of advanced lymphedema and advanced chronic venous insufficiency certainly can decrease the skin integrity and barrier, and we'll talk about some of these complications. And then even some of the causes of secondary lymphedema in and of themselves. So cancer being the most common cause in the US, but also chronic venous insufficiency, surgery, radiation, so on, carry their own additional infection risks as well. So these limbs are at enormous risk for infection. I wanted to briefly touch on how we categorize skin and soft tissue infections sort of generally in medicine and ID, because I think it's a helpful way of structuring how you think about these infections. From our perspective, it helps us think about what organisms are most likely causing these infections and therefore what treatments might work. So one of the most important ways that we try to categorize SSTIs is into purulent versus non-purulent. Purulent being associated with any kind of fluid collection or abscess. So it can be a teeny abscess in a hair follicle like folliculitis, up to larger abscesses like furuncles or carbuncles. And these are almost always going to be caused by Staph aureus, MSSA, MRSA. And this is in contradistinction to non-purulent SSTIs, which are not associated with fluid collections. And this is more your cellulitis, your erysipelas, which is really just a superficial version of cellulitis. And these are more likely caused by strep organisms. Can they be caused by staph as well? Yes, on occasion, but more likely strep. These are really, when we look at our lymphedema patients who get complicating skin and soft tissue infections, we're much more often seeing non-purulent SSTIs than purulent SSTIs. You know, the classic presentation, which I'm guessing you've all seen, is someone who has sudden onset in that lymphadematous limb of sudden erythema, warmth, tenderness, often in association with systemic symptoms like fevers, chills, they feel sick, and they're often having non-purulent cellulitis type infections. Before we talk about treatment for acute skin and soft tissue infection, I just wanted to veer off for a second and talk about a couple of important cellulitis mimickers that I think we see a lot and can be tricked by. This is probably the most common one, I would say, when we are called on the inpatient infectious disease service for a patient that got admitted with cellulitis and has been treated for several days and it's not getting better. Is it a resistant organism? And we go see them. This is often what's there. And this, I'm sure you've all seen, is stasis dermatitis, which is basically a hypersensitivity reaction in the limbs to chronic edema from venous stasis. And so how can we tell the difference between this and cellulitis? There are a few different ways. I would say that in general, bilateral, simultaneous lower extremity cellulitis is a very rare phenomenon. Can we see it? Yes, maybe. I think in 20 years, I've convincingly seen that maybe once. But generally, that is an statistically uncommon phenomenon to get this exact onset of cellulitis in both legs at the same time. And so if someone's giving you that history, this is something you should be thinking about. It's almost always going to be associated with edema because that's the underlying insult that's causing the reaction. It's typically chronic, although there can be exacerbations. It can be tender, but it's most often not, although it's sometimes itchy. Think about what eczema feels like. And generally, there would not be fevers, chills, or other systemic symptoms with this, and there would be associated findings of chronic venous congestion, often in those limbs like hemosiderin deposition, varicosities, ulcers, and so on. This is another cellulitis mimicker that I think is important to mention to this group because I think you probably see this as well. And so the story here, it would be this image down here on the left. The story would be sudden onset of tenderness, maybe a little bit of warmth and induration along the medial lower leg. And this is acute lipodermatosclerosis, that image on the left there. And so what is lipodermatosclerosis? That is essentially a fibrosing panniculitis, so fibrosis in the fat layer of the subcutaneous tissue that happens in patients with chronic venous insufficiency. But when it happens acutely, it can occur with very indurated inflammatory tissue that can be quite tender, usually along the medial ankle, and typically unilateral. So the physiology behind this is not clearly and completely understood, but the theory is that the chronic edema that is happening in the skin and soft tissue is leaving behind white blood cells. They're releasing inflammatory mediators, which over time and chronicity cause collagen deposition and ultimately fibrosis in that fatty layer. And so this can go from something that's local, medial on the lower leg, ultimately to something that becomes much more circumferential and really fibrotic with thinning skin in the area. And the end result is this picture here, which I'm guessing you've probably seen in some of your patients as well, when you have enough fibrosis that it's really just fibrosing down all of that soft tissue around the ankle, forming this inverted champagne bottle appearance to the leg. And that just really further impairs venous and lymphatic drainage and puts this limb at even higher risk moving forward of recurrent infections. And then I don't think any talk in New England about red legs would be complete without mentioning this cellulitis mimicker here. So this would be someone over the summer coming in to see you for their follow-up and mentioning that they have this area of redness on their leg. And this is early localized Lyme disease or erythema migrans. And I think the main point I wanted to make here is that, we see this in all shapes and sizes. People think of it as a bullseye lesion, and it often is, but it certainly isn't always. And people get fooled into thinking this is cellulitis. Often, it can look very different depending on what the pigment of your skin looks like. And so just wanted to mention that this is not something that your lymphedema patients are going to be at any increased risk for beyond the typical patient, but they can certainly get it as well. And so if you see something like this is happening usually days to weeks after the tick bite. They can have some systemic symptoms with this, although they don't always. And this is something that if you think you're seeing it, I would send them to their primary care doctor, who should be well versed in diagnosing early Lyme disease. This is a clinical diagnosis. Blood tests won't help at this point. But generally, when we see this on a patient in this area, we're treating for early Lyme. So in terms of quick overarching points about treatment for acute skin and soft tissue infections, I know you're all not prescribing the antibiotics, so I'm not going to go into these in a lot of detail, but I sort of put them up there so that we could quickly review. So for purulent skin and soft tissue infections, which I already said are really not the more common ones that you're going to see as a complication of lymphedema, incision and drainage is really the key and often the only treatment that these patients need. But if they have more involvement of the local surrounding skin and soft tissues or systemic involvement, then we certainly give antibiotics that will cover staph. For the non-purulent skin and soft tissue infections like cellulitis and erysipelas, they are more commonly caused by strep, but when we're seeing them acutely and patients are ill and sick with them, we usually use antibiotics that will target both strep and staph organisms. So reaching for cephalexin for oral therapy, dicloxacillin, cefadroxil would be common first-line therapies for this that would cover both. Typically, we don't feel like we need to cover MRSA up front in patients who are presenting with cellulitis. Times when we would feel strongly that we should would be if the patient was very sick and having sort of more severe local or systemic illness, they're getting admitted. Those are situations where we might start MRSA coverage up front, or if they have clear risk factors for MRSA, like a history of a prior MRSA infection or colonization, they use injection drugs, they have penetrating trauma, or some other reason to really think about it or be concerned. In terms of non-antibiotic therapies for acute SSTI treatment, just a couple of things which I know you're all very familiar with. First is elevate the extremity. I can't tell you how many times we get calls in the inpatient service about a patient admitted with cellulitis and it's not getting better quick enough. The team is worried that people are failing, and you go in the room to see the patient and they're sitting by the side of the bed. They've been sitting there for hours. The legs are hanging down. They're watching Law and Order and eating lunch, and they are not elevating the extremity at all. And so it's a really important intervention that I think gets overlooked a lot. And so we tell patients knees above hips, feet above knees, and everything above the heart. And that's going to be the most effective way to elevate. You want to manage underlying and associated dermatologic disorders, certainly. So dryness, if they do have stasis dermatitis, if they have tinea, all of these things should be managed. And then manage the edema as well. I wanted to say a brief word about compression during acute infection because I know that it is often recommended not to use compression during acute skin and soft tissue infection. And that is really not based on any solid evidence base that that is the wrong thing to do or that that worsens anything about acute infection. It's based on theoretical concerns, really, that you might, I guess, worsen the infection by compressing it or compress the local lymphatics and make it harder to resolve the infection. But I will say that there's really no evidence to suggest that that is a concern that is actually borne out. And what I will tell you and wanted to show you is that there have been a couple of very small trials, which I was able to find, both published in Germany, actually, looking at compression therapy during acute cellulitis and showing that it's probably safer than we've given it credit for over the years. This is a really small prospective randomized trial that was done of only 37 patients who got admitted to a center in Germany with cellulitis of the lower leg, and it compared applying medical adaptive compression wraps within 24 hours of antibiotics being started versus standard of care. And they looked at CRP levels. They wanted to kind of look at systemic inflammation and then secondary outcomes of patient symptoms and redness. And they found in this trial that in patients who had initial CRPs that were elevated, they had a significant decrease in the CRP as well as a decrease in patient symptoms in the group that received compression after those first 24 hours of antibiotics, as opposed to the group that got standard of care. And I think more importantly, they didn't see any worsening of the situation or condition in patients who were treated with compression more acutely. So, I don't think this is a definitive answer. This was actually, if you look at the details, not a very well done trial. The randomization did not work out well. And so the groups were actually a little bit different. More of the patients in the compression group had obesity. They had more recurrences previously of cellulitis. The other group had more diabetes. And so it's a bit messy. They didn't go into too many details about these patients' predisposition to cellulitis. So we don't know how many of them had chronic venous insufficiency or lymphedema. And so this is not like the answer. But what I will say is that I think we don't know the answer. Nobody's studied it really well. But there isn't necessarily a clear signal that you're going to worsen things by compressing during acute infection as well. So I think if a patient has been on antibiotics for a day and they need compression for other reasons and they can tolerate it, based on their pain, and they don't have some other contraindication like really bad arterial disease or a really big active ulcer or something like that, compression might actually be helpful. I wanted to detour just for a couple minutes to talk about chronic lower extremity ulcers. Again, not because lymphedema often causes these, but because these other comorbidities often travel with lymphedema. And once an ulcer is there, it dramatically increases the chance of skin and soft tissue infection in these patients. So just a very quick overview. The top type of ulcer here, these are the most common types that you'll see in the lower extremity, would be a venous insufficiency or stasis ulcer. These are most common in the supramalleolar region medially. They're superficial. Typically, they're associated with edema and those other changes that you can see from chronic venous insufficiency. And generally, treatment is with compression and elevation exercise. Arterial insufficiency ulcers certainly occur. They're less common. They're typically located more distally in the toes, sometimes over the tibia. Lateral malleolus, these are generally associated with some necrosis and necrotic eschar and very kind of clear punched out borders. The skin surrounding is often cool and hairless. And these are treated with revascularization. Then diabetic foot ulcers are sort of a different bird, generally located on the plantar aspect of the foot. And surrounded often with significant callus and a foot that doesn't have very good sensation, which is how it got there in the first place. And we treat these obviously with trying to control people's diabetes and offloading them. I think that my main take-home point on chronic lower extremity ulcers for this group would be to try to get patients expert multidisciplinary wound care as soon as possible. If you're seeing patients and they have this and they're not already hooked into that kind of care. I've listed for you here multiple indications for referring these chronic wounds. And so I'll leave that there for a few seconds so you can take a look. But I would basically say that if you're seeing anything like this cropping up as you're looking at that patient's feet and legs, and they're not already hooked into a multidisciplinary wound care center, would reach out to their primary provider and make a suggestion that that happen as soon as possible. And we have several of them affiliated with Beth Israel. There's one at BI Needham, one at BI Plymouth. There's one in Anna Jakes. And so there are wound care clinics in the area. Okay. And I wanted now to transition into prevention because I do think this is the most important part of the talk. Anything that we can do to try to prevent. So we know that in patients with lymphedema, anywhere between maybe 10 to 40% of them are going to get a skin and soft tissue infection. And once they do, their chance of getting another one is more than half of them will get another one. So we really do have a job to do here in terms of trying to prevent. And so one of the most important things we can do to prevent is manage the edema, recommending weight loss, regular physical activity and exercise, and then the compression therapies that we have that I know this group is very aware of. I did want to point out a better study that we have showing that we know that compression really does decrease the risk for recurrent skin and soft tissue infections. And so the role that you all play in this aspect of care is really essential. And so this is also a small study out of Australia, but it was much more rigorously done and ended up being published in the New England Journal back in 2020. It was a single center randomized controlled trial of daily compression versus placebo in 84 patients who had chronic edema, so more than 3 months, and had at least 2 episodes or more of cellulitis within the last 2 years before enrollment. And they gave patients 2 sets of compression garments. If the edema was severe before, they may have had a short period of therapist applied compression, and then were given the compression garments to use. I think something like 88% of them used them more than 4 times a week, so adherence to this was good, and it was actually stopped early because of efficacy in the compression group was so good, with the primary outcome being a substantially significant decrease in recurrent cellulitis. So compression works, and so anything we can do to emphasize that is incredibly important. Vigilant skin and wound care is also important. I put this table here, which is from a nice review article that was done on the topic, but any counseling that you can do for your patients on this when you're taking care of them, I think is also incredibly important. So making sure they're having daily hygiene with moisturizing soap, that they're avoiding skin damage to the extent that they can, protecting themselves from sunburns, insect bites, cuts, and when they get these things, to take them very seriously, apply topical antibiotics, keep wounds covered, things like that. Daily application of emollients in order to keep the skin moist. And then when they end up with any skin problems, get them managed immediately, either by their PCPs or by dermatology, but get them the kind of management that they need for things like stasis dermatitis and other complications. Smoking cessation, addressing hyperglycemia and diabetes, and then taking meticulous care of their feet. The eyes are the window to the soul, and I think the feet are the window to the legs, essentially. And so anything you guys can do to help manage that is incredibly important. And so this was another of what I think is one of the important slides from this talk, which is a word on athlete's foot, because this is another thing that while you're working on their legs and you look at their feet and you see this, you can make a huge difference here, because there are tons of over-the-counter remedies that will make a big difference and are very effective for treating athlete's foot. And so if you look for it and find it and can recommend those to the patient, you could substantially decrease their risk of another skin and soft tissue infection. And athlete's foot comes in many flavors. There's sort of your classic interdigital type, which can look either kind of wet and macerated, like you're seeing here, usually between the third, fourth, or fourth and fifth toes, or kind of more dry and hyperkeratotic. But these are both tinea pedis. There's kind of more diffuse or moccasin type tinea pedis, which you can see here, which really just involves the whole plantar surface of the foot and along the edges here. And then there are less commonly seen, but more advanced types of tinea, like vesiculobullous lesions, ulcerative lesions. If you're seeing stuff like this on feet, I think a referral to see somebody in dermatology is probably important. But these types, I think, would be very reasonable for you to recommend to the patient some over-the-counter treatment. And so there are lots of over-the-counter treatments that work well. I would say pick one and recommend it. There's not necessarily one that's better than another. They should apply it as directed and continue it for 4 weeks, and then 1 week after the symptoms resolve. But you can basically pick your favorite. My favorite is terbinafine, which over-the-counter is often marketed as Lamisil, but has other versions as well. But a lot of the azoles will work as well, clotrimazole, miconazole. So just pick your favorite and recommend it. We do sometimes give oral oral antifungals if it's refractory or more diffuse. And so that's something we could help with an ID. And then counseling them about how to avoid getting it again, super important. So all of those points there, drying their feet, wearing flip-flops if they're going to be in public areas, avoiding tight-fitting shoes or things that are going to increase the sweat and moisture in between their toes. And then finally, the role of antibiotics. So what do we do? So let's say you have a patient who's had a couple of infections in their limb within the last year. That is a patient that it's very appropriate to refer to us in ID for help thinking about the role of antibiotics in prevention. And so what do we do when you refer them to us? We look between their toes and treat their tinea if that hasn't been done yet for sure. And then we talk to them about long-term prophylaxis because in addition to compression, this is another thing that we know really can decrease their risk of recurrence, future skin and soft tissue infection by more than 50%. And so this is often directed. We usually choose antibiotics in the setting that are directed at strep species. And so often PO or IM penicillin is first line. And that is what we tend to use if patients can tolerate it. And then we tell them that we're going to do it if they can tolerate it for a trial of 6 to 12 months, see how it goes. And if they're tolerating it well and it's helped, sometimes we'll continue it longer than that. If they have any problems, we go back to the drawing board. On occasion, we'll give patients antibiotics to take with them as needed at onset of infection. These are generally patients who either are on prophylaxis and are still having recurrences, or have had a really serious sudden onset recurrence that's been so bad it got them to the hospital. And maybe they're going to travel somewhere and they want something to take with them, or they live far away from the hospital and they want something to have. We'll give them something that covers strep and staph and tell them to take it at onset of the symptom, but then to seek evaluation. It's something just to kind of keep things contained so that they can get into a hospital for more expert evaluation. And then I know that we are basically only have 2 minutes left, so I'm going to make this very quick, which is a word on filariasis. So like I said, globally, most common cause of chronic lymphedema by far, it's a parasitic infection caused by mosquito bite that is very common in tropical areas, really across the globe. You can see all those blue areas on that map there have these filarial parasites. And these are the areas, there are 3 different types of them, but these are the areas that patients can get exposed. So really, it's a lot of different areas. And basically, the infected mosquito basically injects the larvae into the system of the patient, and then these adult worms grow in the lymphatic system. And over the course of years, patients can develop chronic lymphedema from this organism. And so if you are worried about a patient that may have come from one of those areas and they have otherwise unexplained lymphedema, you can send them to us. We're happy to see them. What do? We pull up this WHO map and we look to see if they came from an endemic area and if while they were there, there was still active filariasis there, because there have been a lot of global mass drug administration efforts that have really eradicated this in certain areas. But if they've come from an area where it was active and they're at risk, we'll talk to them about whether or not to test them. One important thing we always carry in our head is that the adult worms live in the human for only 6 to 8 years in total. And so if you have an immigrant from an endemic area who's been out of that area for the last 6 to 8 years, it's very unlikely they still have active filariasis. And for the most part, what we're doing is helping to manage lymphedema and helping to prevent the complicating skin and soft tissue bacterial infections. But if it's someone who's emigrated more recently, then they could actually still have active lymphatic filariasis. And in those cases, we absolutely want to see them, evaluate them, and try to help. All right, so that's the end. That's what I had for you all. I apologize for going over a little bit what I had planned. These are the key take-home points, which I'm just going to leave up there for you guys to take a look at, but also just wanted to stop and see if there were any questions.
Wendy, thank you so much. That was phenomenal. Great overview and there's the full spectrum of how to manage these patients. And I think one of the big takeaways I had, which I think I know and I try to push towards patients a little bit, is the essential nature of the edema control, because that's really the driver of so much of this. And further emphasizes the point of how important our lymphatic therapists are in helping to manage this aspect of their disease as well. Because I think the patients we really struggle with are those that have really difficulty controlling their edema. They're obese. They just can't maybe don their garments and they're just coming back recurrently. So getting them in quickly So in the chat, there's a couple questions. Angela Serig said, wonderful talk, phenomenal talk. The photos and naming of different conditions look very familiar to legs. Patients we see, helpful to hear about recurrent infections and the use and setting of cellulitis. Wondering if we see redness in lower legs, better to refer first to dermatology or ID?
So I guess I would say that if it is something that seems like a more chronic redness in the lower extremities, and you're thinking that it might be a more chronic skin condition like a dermatitis, I think derm is probably a good place to start. But if you have somebody with a very acute onset, then I think getting that person to the quickest clinician who can diagnose and manage cellulitis is important. So sometimes that might even be their primary care doctor. But once you've diagnosed an episode of cellulitis in that patient, I would say that's a reasonable patient to think about seeing an infectious disease doctor even before they have the next recurrence because they're so likely to have another recurrence that I don't think it's unreasonable for us to see them and at least plant the seeds, and then we're available to them in the future if they do have recurrences. But if it's been more than two recurrences in a lower extremity of diagnosed cellulitis, that's a setting where I would say referral to ID would be very reasonable.
And then Katrina asked a little earlier in the talk, I think this is when you had the slides of lipodermatosclerosis up. She said,
Mhm.
"Is it looks like hemosiderin staining. How can you tell the difference between the two?"
Yeah, that's a great question. And I feel like I learned more about lipodermatosclerosis preparing for this talk. I feel like I've seen it for years and not necessarily known the name to call it. And so I think hemosiderin deposition can happen in any of these legs, right? As long as there's chronic venous insufficiency. And so sometimes when you see it, you'll still have a leg that the skin is soft and it otherwise seems like kind of normal consistency, whereas the lipodermatosclerosis ends up really feeling more firm, kind of almost like a brawny feeling. And then that thinning of skin is often associated with it as well as the pigment deposition. So I think it's a combination of things. I think it can be hard to tell the difference, but I think definitely sometimes you'll see hemosiderin deposition and in a leg that otherwise seems pretty normal, other than a little bit of edema.
Yeah, I think that's a great point. I think it's definitely a spectrum, and you could sometimes be in the middle. I'm like, oh, it kind of has some features of lipodermatosclerosis, or it could just be more significant hemosiderin deposition. But I agree, it's really that soft tissue change, and the then follow up skin fibrotic changes that help differentiate. I would say most hemosiderin deposition itself isn't painful or tender, where once you get to
Mhm.
lipodermatosclerosis, they can kind of like jump off the table with pretty light touch. That was excellent, Wendy. I really mean that was one of the best talks we've had so far. It's so informative for all of us. So greatly appreciate your time. We're definitely gonna have to have you back in some form or another. Have good holidays, everybody. We'll circle back, probably shooting for February, March timeframe for our next webinar. I think it's going to be focused on primary lymphedema with Dr. Aaron Green from Children's. Thanks so much.
Thank you.
Bye, Wendy.
Bye bye.